So I'm very pleased to introduce our first double act. We'll have a triple act tomorrow, but this is a double act by Professors Basil Sharrack and Joan Snowden. Many will be familiar with both. Professor Sharrack is a professor of neurology at the Royal Hallamshire Hospital and the director of the Sheffield MS Research Clinic. Among his awards as royal credentials, the 2020 Queen Anniversary Award. And there's John Snowden, who is the director of blood and marrow transplantation in Sheffield, and also the president-elect of the British Society of Bone Marrow Transplantation. And I trust you all have heard of the slogan, "This is the future, it will be Sheffield made."
Thank you very much really to Gavin for inviting us to come and give the talk, and for you to agree to give us the opportunity to talk to all of you. We would like first to pay tribute really to Her Majesty the Queen. This is when she was in her 80s, when she came to visit us in Sheffield, when we opened the research institution, really a role model for all of us. I met John really many years ago, and we've been working on this for some time. And we work in the same building, and he spent a lot of time in my office. Not really quite sure if this is because of my personal charm or because I have a very good coffee machine in my office. But he would like to make a start first, and then I'll take over.
Just go back a slide. I think you can hear me okay. I think that's you, Basil, isn't it? That's from you, too modest. Anyway, good to remember Her Majesty today. Okay, well, this is the UK media's take on autologous stem cell transplantation in MS and other autoimmune diseases. So I'm a haematologist, so I treat a few different autoimmune diseases amongst all the other usual things that haematologists treat. So this was Fergus Walsh's take, a game changer, and this was the sort of tabloid headlines in 2018. But I think the point I'm going to make is that this has been around for a long time, at least as a concept, and also as a clinical treatment in clinical trials and small series, really since 1994, 1995, when the first patients were treated for MS with an autologous stem cell transplant. And it's gradually accumulated velocity and momentum. MS is the fastest growing indication for autologous transplantation in the EBMT. It's not the commonest, but that's still myeloma, but it's the fastest growing, or at least was before the pandemic. So you're all neurologists. I'm sure a lot of you have done a bit of haematology in your general medical training, but what we're talking about is a procedure which is very common in I would say tertiary and some secondary level haematology departments. That's the autologous stem cell transplant. It starts off with a stem cell harvest. You mobilize, usually with chemotherapy and granulocyte colony stimulating factor. You collect the stem cells in a bag and you freeze them down. It's all very routine. And you can keep those stem cells for as long as you like, but most of the time we do move on to the so-called transplant. It's not even a true transplant, it's the patient's own cells. We go into the transplant, which is usually done as an inpatient. Patients receive this conditioning regimen, which for MS is mainly anti-thymocyte globulin, ATG, and cyclophosphamide, but there is another regimen, Beam ATG, which is more common in places like Italy. And then at the end of this period of hematopoietic and immune ablation, we thaw out the cells and we give effectively the stem cells like a blood transfusion. It's quite straightforward. There's no major transplant as such. And then we've got the tricky bit is tiding the patient through the following 2 to 3 weeks, where we need to support them with transfusions of blood, red cells and platelets, and with antibiotics and other supportive care measures. And after about 2 weeks, we'll see reasonable neutrophil and platelet recovery, and that's getting the patient through the inpatient phase. And what we're taking advantage of here, and Professor Paolo Marraro is in the audience, is this altered immune reconstitution that occurs after an autologous stem cell transplant, which can, in some autoimmune diseases, taken in the right phase of the autoimmune diseases where there's inflammatory activity, result in some immune re-education or immune rebooting, rediversification of the T cell repertoire, a surge of T regulatory cells, and so on. So that's the procedure. As I've said, the concept is not new. I keep changing this slide. It used to be about 2 decades old, and then now it's 3 and 4 decades old, because the ideas were there in the 70s and 80s. There were animal models during that time, and even Richard Burt who's been a leader in this field, he published in 1995 his work done at the NIH. So this work was ongoing for some decades, and on a clinical level, us as simple hematologists, we used to treat patients with leukemia or aplastic anemia with a transplant, and quite commonly we saw resolution of or cure of both problems, and there are lots of case reports supporting that clinical level evidence. And this led to the first patients as far ago as 1995 treated with AHSCT specifically for MS, and this was done in Thessalonica and also in Chicago. Thereafter, the EBMT, this is my organisation, it's a bit like ECTRIMS or EAN, formed an autoimmune diseases working party. It incorporated autoimmune diseases into the database and started producing guidelines. There's been lots of generations of guidelines in all sorts of diseases, but these are those most recent ones led by Basil, Paolo, many others involved in the field, specifically for multiple sclerosis and immune-mediated neurological diseases. And these are some very general guidelines. I'm just putting them up because they're just fresh out, and I was involved in leading them. But multiple sclerosis is there as a standard of care recommendation based on the fact that there's randomized controlled trial evidence in relapsing remitting. It's there amongst all the leukemias and the myelomas, and that's why it's become the fastest growing indication. So I'm just going to touch briefly on the registry data. The EBMT is one of the strengths is that it's got just about every transplant that's performed in Europe from about 1980 something within the registry. And as I've mentioned, the autoimmune diseases have been accumulating since 1995. And so in terms of autoimmune diseases, there's almost 4,000 procedures, and the vast majority of them are autologous transplants. These are the self stem cell transplants because they're more straightforward and safer. There are a handful, I would say, over 25 years of allogeneic transplants. You can see that they've been done mainly in pediatric patients, not for MS, I should add. But MS is by far the most frequent indication of all the autoimmune diseases within our registry. Others include scleroderma, lupus, Crohn's, and so on. But there's over 2,000 patients that are registered, 2,000 transplants that are registered in the EBMT database with MS. This is another way of putting that rise. MS is in blue. These are all the autoimmune diseases. Systemic sclerosis is in green, Crohn's is in red. But you can see MS is the predominant indication. It's been rising. and then there's been a drop-off since the pandemic, which was a cautious move on behalf of the transplant community. This is the slide that summarises the progressive rise of MS and the recovery after the pandemic. These are the countries where it's become more frequent to do transplants for MS. And as Basil says, it's down to the chemistry. It's not just, it's partly the MS community accepting that this has some potential. It's also down to the fact that I think hospitals like our own, and we've got combined neurology almost and haematology in the same building. It's harder if you've got a separate neurological unit that's miles away from the transplant unit. So some countries, some centres have evolved their experience. UK has just overtaken Italy. San Raffaele is a big centre, as is Firenze and Genova. You'll know the people that are involved in this collaboration. But if there is a prize to be had per head of population, the Swedish would win, because Sweden's a small country compared with Italy and the UK. So I'm going to hand back to Basil to talk about the evidence in the field.
So we had excellent talk from Emma earlier, which really sort of set the scene for us. And Emma told us about the interaction between inflammation and degeneration, various stages of the illness. And she also reminded us really that if you believe really, once you've reached a level of disability, then regardless how you got there, things will get worse gradually thereafter. It is therefore very important for patients with active disease to be treated, if appropriate, as early as possible. We also, you remember the work done by Alistair Coles using alemtuzumab, when he used the treatment late, didn't really sort of suppress the illness, suppress the inflammation, but didn't really suppress the progression of disability. This is really similar data from Ottawa using stem cell transplantation. And you can see all these patients had a lot of active disease, a lot of relapses, MRI scans activity, and then once you've given the stem cell treatment, everything goes very quiet thereafter. No further relapses, no further inflammation. But many of those patients were really getting worse, already getting worse. And you can see that many of them, the disability will get better, but those who are getting worse will just continue to get worse anyway, regardless really whether they have active disease clinically or radiologically or not. And again, we learned about really sort of NEDA, whether you believe in it or not, but as an outcome measure, indicating that once you've given it the treatment, you will suppress it, so no evidence of active disease clinically, radiologically, and no evidence of relapses, then this is really sort of the NEDA figures of the drugs that we have at the moment at 2 years. So the best you can achieve with that at 2 years will be a NEDA of about 50%. So you can suppress your illness, the illness of your patients, in about 50% if you use powerful agents like ocrelizumab, for instance. The worst you can do with stem cell transplantation is suppression of about 70%, a huge difference between them. Amazingly, all the data that we have in relation to stem cell transplantation doesn't come from clinical trials, comes from cohort studies, whereas, of course, the evidence of that comes from clinical trials. So this is the Ottawa data I've mentioned earlier. You can see that they treated 24 patients, and they really achieved marvelous results, really, of suppressing this activity quite aggressively. They used really an aggressive regimen using busulfan, and you can see that they've lost 2 patients in the process of doing that. This is data from North America, from Seattle, and again, really, so they treated 25 patients with another regimen, which is less toxic than the busulfan one. But again, really, the results really are quite amazing. And they note that treatment-related mortality was 0. This is the Swedish data, and again, they treated around 50 patients, mainly with relapsing remitting multiple sclerosis, and again, treatment-related mortality is 0. But you can see really that they've achieved similar results, but here we can see really who responds and who doesn't. So those patients who have active disease in terms of GAD-enhancing lesions do better. Those who have the illness for less duration, they do better. Those patients who are not very disabled will do better as well. This is data from Chicago, Again, 145 patients treated, no treatment-related mortality is 0. Again, amazing results, as you can see. But for the first time, Richard Burt showed really that those patients who were treated got better in terms of disability. So the EDSS got better really by about 1 point, which is really unheard of in clinical trials of multiple sclerosis. But remember, this is not a clinical trial, this is not a randomized trial, this is a cohort study. And then Paolo looked into European database and the North American equivalent database, and again really sort of got similar results really as well. So the best results are obtained in those patients who have relapsing remitting rather than progressive multiple sclerosis, and again those who really have the illness for shorter period of time and who are not very disabled. And then similar results were obtained here in London from the London group. And there are other cohorts. There's a cohort from Australia, and there's a cohort also from Italy, very famous cohort from Italy, which I'm not going to mention. But the largest cohort ever is again from Chicago, 500 odd patients treated, again really sort of showing that results are replicated. But Richard Burt has always insisted that if you don't have active inflammation, then you have no response. He always said really that this treatment should be offered to patients with active inflammation, active disease. And that's been reflected by what's happening really in Europe. You can see that more and more patients with relapsing remitting disease being treated and less patients with progressive disease being treated using this treatment. Amazingly, only 2 randomized trials have ever really been published. This is a phase 2 study on 21 patients, mainly with progressive disease, trying to look into the efficacy of stem cell transplantation against mitoxantrone using MRI scan as a parameter. And again, no treatment-related mortality, and you can see the difference is really is very obvious. The only phase 3 study is this one. This is the MIST study, which was done in Sweden, United States, Brazil, and the UK. And in that study, 110 patients were randomized into 2 groups, either to receive stem cell transplantation or the most appropriate disease-modifying treatment. Those patients had very active disease, 2 or more relapses in the previous 12 months, despite being on disease-modifying treatment. And we looked into disease progression of disability using the EDSS. And the results really were quite astonishing. You can see that in those patients who received stem cell transplantation, only 3 out of the 55 patients progressed, whereas 34 patients who received the standard treatment progressed. And again, we replicated the improvement of disability in those patients who received stem transplantation. EDSS dropped by 1 point. But what was needed really is, if I go back, the treatment, standard treatment arm in this trial, because the trial was done about 10 years ago, we progressed over about 10 years, did not include any of the highly efficacious treatment that we have at the moment. So that's why we needed such a trial. And in fact, there are 3 trials ongoing at the moment to look into that. The North American trial, the Swedish trial, the Scandinavian trial, and the UK trial. And there is a trial in Italy which is really in progress. There was a German trial which has been put on hold at the moment. So, does this treatment have a role in the algorithm, particularly on those patients who have really not failed disease-modifying treatment? Yes. Well, this is the UK algorithm, and you can see that, well, you're probably not going to be able to see that. It's really stem cell transplantation is in the bottom, can only be used as the rescue medication, a 3rd-line treatment, and that doesn't really look right. ENA and ECTRIMS suggest that we have to treat our patient with active disease as early as possible. And in fact, if you use stem cell transplantation for treatment-naive patients with active disease, you can suppress the illness completely. So once reviewing the treatment, patients will have no further relapse thereafter. Is that a cure? But you can also really sort of improve disability markedly in this group of patients. And as John said a little bit earlier, the current guidelines, these are consensus guidelines, suggest that those patients with highly active disease, failing disease-modifying treatment, should be offered stem cell transplantation as a treatment, as a standard of care. Those patients who have aggressive disease, they should be offered the treatment option, and those patients who have progressive disease with superimposed disease activity should be offered the treatment as well. And I'll hand over to John now.
Thank you, Basil. So we're just going to talk about some current questions that surround this field for HSCT in MS. And I'll just touch on the transplant regimen, and then I'll hand back to Basil, because this is a sort of hematological area. But as you probably know, that there isn't just one transplant regimen. It's a variety of different combinations of chemotherapy. Sometimes we even use radiotherapy. Sometimes we use antithymocyte globulin. But I'll just give some examples of the diversity between different trials and their impact. This was an Italian study led by Riccardo Siccardi and Gianluigi Mancardi. And they tried to reduce the intensity of the conditioning regimen. Rather than giving their standard beam ATG, which is quite a hard regimen, well tried and tested, they reduced to cyclophosphamide 120 milligrams per kilogram plus ATG. And they found that it wasn't as effective. Maybe it was safe. It wasn't that many patients. I think they probably realised that we were going to stick with beam ATG. Beam is a lymphoma regimen, but in MS it's combined with antithymocyte globulin. On the other hand, and Basil's already shown this slide, and you'll have seen this data in the Lancet, the Canadians in Ottawa treated 24 patients with this pretty, it's sort of like what we call in Sheffield the full Monty, really. It's cyclophosphamide, 4.5 grams per metre squared just in the mobilisation. And then they went on to busulfan, cyclophosphamide ATG, which is a tougher regimen that we use for leukemias and so on. And then they CD34 selected their autologous transplants. So I think they were doing the right thing by making sure that they immune ablated. They ablated the blood, the hematopoietic and immune systems. But we can talk about the results, because the results were impressive, but 2 patients in 24 developed veno-occlusive disease, which is a rare complication that you see with transplantation, rarely in autologous transplantation, and 1 of these episodes led to treatment-related mortality. So it's a bit like a game of blackjack. You don't want to go too far, you don't want to be too soft, and you have to find a compromise. So the EBMT recommend 2 regimens, and I think the compromise is in this cyclophosphamide 200 milligrams per kilogram plus ATG, or the beam ATG, and that's what most of the transplants around Europe have been treated with. I'll hand back to Basil, and who's going to talk about how much benefit over standard of care does transplant have.
So I think I'll talk about STAR-MS. This is the study that is happening in the UK now. And this is really to answer the question, is stem cell transplantation more or less effective than highly efficacious treatment? So this is a study which were run in 18 sites in the UK, throughout the UK, excluding, sadly, Northern Ireland. And it will randomize 198 patients into the 2 arms as suggested to try to answer that particular question. And we really wanted also to try to understand the mechanism of action of stem cell transplantation. The primary outcome measure is NADA, so that's NADA-3. But there are a number of secondary outcome measures. And patients will be followed up over 2 years, and we have plans to follow the patient up for an additional 3 years thereafter, so a total of 5 years. There will be sub-studies, including mechanistic sub-study, which we run by Paolo, and there will be neuropsychology sub-study and OCT sub-study, and also 1 or 2 other sub-studies, including novel biomarkers, which will be done by colleagues really in the Royal London as well. The inclusion criteria are that those patients need to have active disease, and those have been modified really to reflect what we do at the moment. So patients already on treatment, on disease-modifying treatment, if they have one clinical relapse or one MRI scan evidence of MRI scan disease activity, can get into the study, provided they're not being treated by these agents before. Or for the first time, patients with res MS, they can get in the study even if they are treatment naive. We're hoping really that, so as John has said, we'll be using the cyclophosphamide ATG regimen, and then patients will be followed up over a period of 2 years. I'll hand over back to John now.
Okay. Well, in the interest of time, I'm not going to, and we've got Paolo in the audience, and this is a slide from a review that we wrote with Paolo. But as you know, like any autoimmune disease, MS has got multiple hypothetical and proven triggers and predispositions. And what we're doing with an AHSCT is we're ablating the hematopoietic and immune systems with the hope of resetting the immune system. And there's a variety of elements of evidence that are coming through, much of which has been generated by Paolo and his laboratory, where you've got changes in the direction of resetting the immune system to something as it was before the onset of the autoimmune disease, or specifically multiple sclerosis. There's also a great review from our next speaker and Paolo, and of which were published on behalf of EBMT, about the changes that have been shown in relation to multiple sclerosis. So I look forward to hearing more from Dr. Cencioni. So I'm going to talk briefly about health economics and our provision in the UK. The equations seem quite simple. Back in the day, I think these drugs were considered quite expensive, and transplant was even more expensive. So transplants never got funded by the NHS. But then you had the raft of these amazing drugs, this armamentarium you have for MS, and the prices of the treatment eventually went up. However, autologous stem cell transplantation remained relatively stable, and in Sheffield, the NHS cost or the reimbursement that our hospital gets is in the region of 35k, and if you treat a patient privately with an autologous stem cell transplantation, it's around about £60,000, which is relatively comparable, or even less if you're looking at a one-off treatment compared with the ongoing recurrent treatments of the disease-modifying therapies. We've looked at this in a various number of ways, both in secondary progressive and relapsing remitting MS in various health systems, and the NHS has looked at it in various ways. I probably would say that by far the best review that got published from a health economic point of view is the Welsh analysis. This is online, it's all available, but they did a really good detailed review. Ourselves, Paolo, Basil, transplant experts all had an input into these Scottish and Welsh analyses. But the essence is that if it works for a long time, it might be a cure or it might work for several years, AHSCT is going to prove cost effective compared with recurrent rounds of disease-modifying treatment. But more needs to be looked at. Obviously, the newer agents are coming on board, and they've all got a different price tag, so that's part and parcel of forward vision. So, and you can't do a lecture these days without mentioning COVID, which had a big impact on the practice of HSCT in autoimmune diseases, because the EBMT didn't know what was going to happen. You have alternative treatments, so we really broadly recommended that transplantation stopped for most of 1 to 2 years, and now it's gradually rekindling in a very cautious way. There are these EBMT guidelines. So if you want a very recent review on HSCT, There's one in the BMJ. It covers all the issues, and it's in the uncertainties category. So I think there are still a lot of uncertainties, but we hope to be able to answer some of those uncertainties through the STAR-MS trial. If you're wanting very up-to-date guidelines, they aren't published yet. We're still left with the EBMT guidelines, which are a multidisciplinary guideline, but it's dated 2019. And Basil and Paolo are leading on this, these guidelines, which for the first time, they are combined specialty guidelines. That's different from the EBMT, bringing in neurologists and other specialists into the Autoimmune Diseases Working Party. These will be true joint specialty guidelines, so that's a big step forward. We put them together in an ECTRIMS focus workshop, 10th of 11th of March of this year, and hopefully they'll be in press soon. So in conclusion, autologous hematopoietic stem cell transplantation is evolving into standard treatment to be considered alongside modern therapy for MS. And the future depends on the dynamic with modern and future standard of care DMTs, because that's always changing. And acceptance within national and international disease specialist communities and health services. So these combined specialty guidelines should help that. Further studies are necessary to establish the relative benefit over current future standard of care therapy, and we've talked about STAR-MS and all those studies to establish the best AHSCT regimen for each disease. As a hematologist, we're using chemotherapy that's 50 years old or more. I think we can do something a lot better, but that's going to be in the future, I think, with the targeted regimens that could be rolled out in this area. We need to define the mechanisms, and hopefully by defining the mechanisms we'll develop clinical biomarkers to select and monitor patients. Much of that work goes on in Imperial with Paolo. We need to define the health economic benefits and how we deliver it on a public health level. Although the health economic equations are straightforward, you can't believe the controversy amongst the patient groups, not necessarily in the UK, but outside the UK, who can't get the procedures funded, and that's why people, fly off to Mexico and Russia and all those issues that we can talk about at length. And then we need to evaluate the impact of COVID-19 so we can continue to navigate safely. So this has been a cross-fertilisation of specialties. Treating autoimmune diseases by destroying and then selectively rebuilding the hematopoietic and immune systems may not only produce clinical benefits, but also important insights into the pathogenesis of autoimmune diseases, including MS. I'll just acknowledge all of our colleagues in the EBMT, and this is just to tell you where Sheffield is, if you don't know where Sheffield is. It's bang in the middle, in the epicentre of the UK. And this is a meeting we're having on the 20th of January, early next year. And these are the contacts for the STAR-MS study. So thank you very much.